Hello friends, so today I'll be talking about this 35th COVID update on Remdesivir article that came in NEJM on 5th November. So today is 6th November. So we have seen the literature about Remdesivir and more so the recent Solidarity trial which raised question about usefulness of Remdesivir. So on the backdrop of this, this particular study has just come from the ACT investigators. So these are the group of investigators who have come out with a final report on their study. So this was the title of the study, Remdesivir for the treatment of COVID-19 final report. So it was done by ACT 1 study group members on 5th November 2020. So as we all know, this is a double-blinded placebo randomized controlled trial. So the another interesting thing about this study was, I remember even in our own expert committee in our state, we had this debate whether remdesivir should be used only for 5 days or for 10 days. So we do understand the backdrop of one study which compared 5 days and 10 days of remdesivir and did not show any difference. Although in the subgroup analysis in that page, in that particular study, they showed that remdesivir given for 10 days had a mortality benefit in intubated and mechanically ventilated patients. So this was our understanding. So even our state protocols suggested that we should give remdesivir only for 5 days for patients who are not on mechanical ventilator. So that has been our understanding. But if you look at this particular study, they have used remdesivir for 10 days. So 200 mg on day 1 and 100 mg once a day for 9 days. So the primary outcome of this study was to look at time to recovery. So this time to recovery, they looked at 8 category ordinal scale. So they had a scale to determine the clinical condition of the patient or the clinical progression of the patient from either getting worse or from getting better. So the ordinal scale was defined as, so when you say ordinal scale of 1, which means this patient were not in hospital and they did not have any limitation of activity. So the ordinal scale of 2 means, which again they did not need hospitalization, but they had some limitation of activity, or they might be patients with background COPD or asthma who are on home oxygen. And ordinal scale 3 referred to patients who are hospitalized but they did not need any oxygen, but they did not even need any ongoing therapy in the hospital. And ordinal scale 4, which again they were hospitalized, they did not need oxygen, but they needed ongoing care or ongoing concurrent medical management is what they needed. And ordinal scale 5, I think this is something you can keep in mind because this was the group which maximally benefited in this study, is patients who were admitted and needed supplemental oxygen. So this was the group which gained immense benefit with remdesivir from the study in this particular group. And ordinal scale 6 referred to patients who were in the hospital and who needed NIV and HFN. So our whole interest from intensive care parlance starts from ordinal scale of 5, where they need oxygen, and then there may be a cascading increase in the need for oxygen, whether remdesivir does any benefit. And sixth is more sicker who need NIV or HFNO. 7 ordinal scale 7 referred to patient who needed intubation mechanical ventilation or who also needed ECMO. 8 is death. So this was the ordinal scale they looked into to see if remdesivir conferred benefit in any of the, because the patients they randomized could fall into any of these ordinal groups, and they wanted to see which group benefited the most with remdesivir, or whether all groups benefited from remdesivir, so on and so forth. So the secondary outcome they looked at was day 15 clinical outcome and change in this ordinal score category. Whether if someone has come from say ordinal scale of 5, whether they improved to ordinal scale of 4 or ordinal scale of 3. So the delta change in the ordinal scale is what they look from day 1 to day 29. So methods, so they had 60 trial sites. So this was a big randomized controlled trial by ACT investigators. So the predominant sites were from USA, 45 sites from USA, 8 were for Denmark, 5 were from UK, 4 from Greece, and 3 was from Germany, 2 was from Korea, and 1 was from Japan and a couple of other countries. So this was the trial site. So predominantly the population belonged to US. So when you look at the results, the mean age was 58.9 years. and 64.4% were males. As we have seen time and again in these studies, males seem to be more commonly affected. And comorbidities, hypertension, again we have seen this in the past with COVID patients needing hospital admission. The predominant comorbid problem has been the hypertension. Here also it is the same, 50.2 were hypertensive. And we have recognized that COVID has some predisposition to obese patients. So even here, 44.8% of the patients were obese, 30.3% were diabetics. And so the randomization, the symptom onset to randomization was 9 days. So within 9 days, they had to randomize into either Remdesivir group or the placebo group. The interquartile range was 6 to 12 days. So when you look at the results, so where the number of patients in the ordinal scale of 4, which means who were in hospital, who did not need oxygen, and but who needed some ongoing treatment, there were 138 patients. This is a percentage distribution of different ordinal scale. 13% were in ordinal scale of 4, and 41%, which is 435. So as I said, keep an eye on this ordinal scale of 5, because this is the group which had maximum number of patients, and we would look at the benefit also seem to have been bit more in this ordinal scale of 5. Any patient needing oxygen given Remdesivir possibly had a good benefit, and all other groups also had benefit, but this is a bigger chunk of patients who are in this group. And this is the thing. So they looked at recovery rate ratio, which they called it as a rate or a, recovery ratio or a rate ratio is what they called. So this effect size, the effect size of improvement was found to be largest in this group, ordinal scale of 5, which means to say any patients who needed supplemental oxygen where Remdesivir was given, the time to recovery, the primary outcome seemed to be the best in this, because the recovery rate ratio was the largest. 1.45 was the rate ratio, and this is the confidence interval. And the ordinal scale of 6, we had around 18.2%. And the recovery rate ratio here, as you see, is little less. 1.29 was the recovery rate ratio. And patients who were intubated and mechanically ventilated constituted 26.8, and the recovery rate ratio was much lesser in patients who were intubated. That was only 0.98. So what it is only showing is that patients in ordinal scale of 5 appear to gain or have largest benefit with Remdesivir, and this benefit tends to come down as the severity increases. So again it goes on to show that the maximal benefit of Remdesivir can be derived when you give it early at the right timing. So ordinal scale of 5, which we have all subscribed to all across our nation, that someone who is needing oxygen, obviously we wouldn't deprive him of getting Remdesivir, because these are the people who are going to maximum benefit and possibly prevent progression into further worsening, needing intubation and mechanical ventilation. So, and the ordinal scale is 8. So then they looked at recovery rate ratio if Remdesivir is administered within 10 days or more than 10 days. And even here they saw the recovery rate ratio was definitely much better when Remdesivir was administered less than 10 days. Even the previous studies also have shown this. The sooner we give, better is the effect of Remdesivir, and that was clearly shown. If you exceed more than 2 days, 10 days, the effect size of benefit with Remdesivir would come down. So this is what was shown. So when you look at the median, so now looking into the main results, so they had 1062 patients, 541 in the Remdesivir group, 521 in the placebo group. So this is the primary outcome where they looked at the median time to recovery. It was 10 days in Remdesivir compared to 15 days in placebo. These are the confidence intervals. That was statistically significant. And they looked at day 15 clinical improvement. And day 15 also the clinical improvement was much better in Remdesivir with odds of 1.5 and being statistically significant with a narrow confidence interval 1.2 to 1.9. They looked at day 15 mortality. It was significantly less in Remdesivir group, 6.6, but this was not a primary outcome. So this was looked at as a secondary outcome. So day 15 mortality also stood to be starkly better in Remdesivir group. And they looked at day 29 mortality. Hazard ratio was significantly less in Remdesivir group. This is the confidence interval of 0.5 to 1.03. And again, when they looked at mortality, the largest benefit. So you saw in the previous slide, that the recovery rate ratio was better in ordinal scale of 5. Even the mortality benefit, the largest effect was found with an ordinal scale of 5. So these are the patients, and this was the biggest chunk of patients in this study, and possibly in our own practice we see biggest group of patients who stand to benefit is someone who comes early just about needing oxygen, and here there was a big mortality benefit also in this particular group because the hazard ratio was only 0.3 when they did a subgroup analysis to look into the day 15 and day 29 mortality in patients with ordinal scale of 5. So they looked at serious adverse events, and it appeared to be little less in remdesivir, 24.6% versus 31.6%. So this was the the primary major results that were shown in this study. Then they looked at lot of additional secondary outcomes. So what were the secondary outcomes? So they looked at ordinal scale of one category improvement. What that means is, if suppose you have captured a patient with ordinal scale of 5 changing to 4. So how much time did they take to improve from 5 to 4 or 6 to 5 or 7 to 6? So that's what they looked at, delta change in one category component. And that also the ordinal scale change to betterment happened in less time with remdesivir, 7 days compared to 9 days, and that was the rate ratio of 1.23. And they looked into ordinal scale of two category improvement, which means 5 to 3 or 6 to 4. So they looked at two category improvement. That also they saw it took less time in the remdesivir group, and rate ratio was 1.29. And they looked at the discharge. So the patients who were on remdesivir group tended to be discharged early than in placebo, 8 days compared to 12 days, and that was the hazard ratio. And they looked at the median length of stay. For remdesivir, it was much lesser compared to the placebo group. Then they looked at median oxygen requirement. So even the patients who were on remdesivir appeared to have been weaned off oxygen much earlier than the placebo group, 13 days versus 21 days. So if you look at these secondary outcomes, they all look very, very appealing and very, very exciting that remdesivir has shown benefit in almost all parameters. So this was a hugely positive study in that sense. And they looked at the new oxygen requirement also was less in remdesivir group compared to placebo. And then they looked at the patients needing HFNO or NIV from oxygen, which means the cascading or worsening of respiratory distress. This was looked in 573 patients, and less patients who were on remdesivir went on to have respiratory worsening needing NIV and HFNO, 17% versus 24%. And they looked at median duration. If someone is on NIV or HFNO, they looked at the median duration. It remained the same in remdesivir and placebo. Then they looked at duration of intubation. If someone is intubated and they got remdesivir, the duration was slightly less in remdesivir as compared to placebo. And someone who is not intubated and going on to need intubation, they looked at 766 patients, and that was also found to be much less in remdesivir, which means you have treated patients with remdesivir, the possibility of them worsening to needing intubation and mechanical ventilation were much lesser number in remdesivir compared to the placebo. So this whole article, this is pretty much the core essence of this study. So it is a hugely positive study. So the key take-home message is, which is little different from the previous study, is the previous studies have looked at 5 days, but here they have given it for 10 days, and it looks at the primary outcome, which is the time to recovery appeared to be much better with remdesivir. And even when you look at change in the ordinal scale to getting better, it was better with remdesivir. And mortality, which it was looked at not as a primary outcome, also appeared significantly better in remdesivir group compared to the placebo group. And this benefit was seen maximally in patients with ordinal scale of 5. So this was the forest plot, and as you see this forest plot, the whole line moving to the right, which appeared very significant in patients with ordinal scale of 5. So there are few other details about serious adverse events, but pretty much the key take home messages of the results would be pretty much this, whatever I've just said. So thank you very much. So you can read through the paper again. So you may find little bit, so a lot of numbers. So this is the quintessence of this whole paper. So if you wish to rehear to this lecture, you can visit my website www.drpradeeprangappa.com and be here. Thank you very much.